a note below that they pay annual. So if some patients will actually tell you, I have things growing down there. Okay? So if you check such a patient and you find you dealing with the annual skin tags, rule out other conditions which could be associated with them because they have been found patients who have Crohn's disease tend to be having those say annual skin tags. So anytime a patient tells you I have things growing there, sometimes they will explain to you as busundo. So you know busundo. Some people treat it as syphilis. Everything that goes down there nowadays, people will treat it as syphilis. Everyone will tell themselves, "Nina Akawawansi, so Nino Sundo Wansi." So if you check and you really find that these are skin tags like you are going to see, then please don't treat them as syphilis, okay? So allow me drive you to the images of what we are talking about. Mm. So you're going to be seeing what it actually looks like. So there, that thing that you are seeing is known as an acrocolon. Okay, that is a skin tag. That is what it can look like. Now this one was taken from the axilla. Okay, so taking you back again to the same, we're going to look at others when they're a bit many. Okay, the so common skin tags that you will see in our black population, what they actually look like, those ones. I'm sure at least you've seen a patient having such things, and people tend to not to know what brings them or what they are even dealing with. So such a thing is an acrocolon. Those are skin tags. Some of us might even be having them. So please, when you get a patient who has these things, don't be scared. Those are benign skin growths. Okay? Now, like you can see, these ones are actually in the neck. So patients can have the same things down there between the thighs. Yeah, I've actually seen a couple of them here at this. So these things can also undergo some changes or complications, okay? Like the first one that we saw was really a big one. Sometimes it can twist on its own and it actually dies. So what you see in there is a strangulated skin tag. So it can be huge, that if it twists on its own, it cuts off its blood supply, and hence patient comes in with such a thing. Okay, any questions about skin tags before we go to their management? Okay, if none, then we can look at how they are treated. One, they can only be treated if the patient, one, is desiring to remove them, or they are irritating, or for example, it has strangulated like the other one. Short of that, there is no need to really tamper with them. If the patient is not complaining and you just find them as you examine them, please don't touch. Okay? The other methods of management are usually removal, surgical removal. You can do a snip excision with the forceps using fine scissors as well, and you can apply local anesthesia. Some of them can actually bleed, so you may even need to suture. Then others, you can use cryosurgery with liquid nitrogen, or you can do electrodesiccation. Okay? Now, in our setting, what is usually available? If, for example, you have ascertained the client has them, but they are not so many, they are in a small area where you think from your assessment, this client can use silver nitrate sticks or the silver nitrate pencil, you can give it to them. But what you should put at the back of your mind is that it can cause permanent pigmentation of the skin. You know that silver nitrate pencil literally burns, okay? It causes corrosion of the cells around where you have applied it. So you may leave this patient with areas that really show that they had a growth there. So if the patient really has no problem with that, then you go ahead and give them the silver nitrate pencil for the skin tags, okay? Especially the small ones. The big ones, you may want to do the surgical management, but the small ones, you can conservatively manage them or reduce them with the silver nitrate stick or pencils, which are very available. Other things that I actually didn't find about research reporting about them was the use of qualifying paint. That I really didn't come across it in the management of this. However, looking at the way it works, I think you can really employ it. Okay. don't want to say go ahead and use it because the research that I made really didn't bring it out. So I can't stand on my two legs and I tell you you can give it to a patient. It's not to be used in pregnant patients. For the filing, keep it away from pregnant mothers. Okay? Silver nitrate so it is safe, whether pregnant or not pregnant. It can be used. For the filing pains, caution when using in pregnant women. Has been used, but research, I didn't find anything in support of its use. Might be there, well, but I didn't find it. So I think now we've talked about the only other added skin lesion that I had put in the presentation. Now going back to what we were requested to discuss, the color cells and the cones. These are usually commonly found on the feet, okay? That is in our setting, but they can be found in other areas as well. Color cells are just skin hardening or thickening of the skin, and it usually comes as an adaptation of your skin to either friction or pressure at that very point of your skin. Calluses or cones can be found in areas which tend to take on a lot of pressure, areas which tend to apply like the cushion to your body. For example, if a person is walking, you don't put your entire foot down. Okay? So areas which have that pressure of your body being transmitted from your feet to the ground, those are the areas where you will find the cones and calluses coming. Then again, you can have them in the hands. For example, people who dig ekyo bayita amabavu. Okay? Amabavu are literally calluses. They are skin hardening. It's like an adaptation that someone is overusing that part of their skin, so they tend to undergo modification so that that function can be carried out without damaging the rest of your body. So if someone, for example, is putting on very tight shoes, which means your toes are rubbing onto the feet, onto the shoe. In such a case, your body will adapt. Instead of your skin bleeding and causing a wound, it will instead harden and create something that has the same force that is being applied by the shoe. So in case someone is putting on a very tight shoe which is not fitting them, they will come with the callus rather. Okay? This is just an adaptation of your skin. If someone is using a hammer, for example, those guys who use hammers, all they do has labor work. Their hands tend to have those hardened marabu. The marabu is what is known as a callus. Okay? Just an adaptation. People who, for example, sit back like we, you only writing and taking medicine, you may not have the marabu. But if you go to those people who do welding, the builders, those people tend to have they have thickenings, okay? Okay. Then these things can also come in. For example, if someone has an outgrowth of a bone, for example, your cat toe has a bone which is irregularly placed. So it tends to be receiving a lot of the pressure when you're moving. It might also end up having a hardening. It's just an adaptation. Think about it in that way. Your body adapts by making that place stiff. As simple as that. So I will now take us to see the difference between a callus, a mabavu, and then a cone. Cones, okay, let's start with the calluses. The calluses usually develop on the hands and then the feet. So those ones can be found in both places, the hands and the feet. They can be on the toes as well, like I've explained. And if you feel it, the patient will just come in with something that is thick, usually rough and bumpy. Most so it is usually painless. So Amababu are not painful. I think most of us who have done some hard labor work, you can tell that Amababu really, someone can have the Amababu and they are not painless, but wogakwatako gasala n'okusala. That is very normal. Now that is what we call a typical callus. Okay? Then on the other side, cones are usually found in the feet. Like for them, they come down at pressure points or at the toes, like we are going to see in the images. And the cones Despite having a similar presentation like the callus, for them they tend to have a central area. So that area where the skin has modified and it thickens, it tends to have like an eye in the middle of that area and is usually painful. Unlike the callus. Amababu, they are not painful, but when it comes to corns, they tend to be painful. Okay? So before we go to the treatment, let me still take you back to our images. We have a quick look at them. So we shall start with we shall first see the calluses. Okay, see what the calluses look like. So those are the calluses, like you can see. Okay, they usually come. Now these ones were at the medial area of the big toe. Okay, and above. Okay, then we shall now still have a look at the cones. Okay, so unlike the calluses, the cones are way a bit slightly different in such a way. Now, like you can see on this small toe, the diagram up, a hyperkeratotic vacuole with a center. So it's that bump, it's that thickening, but it's characterized by having an eye in the center. Okay, like you can see the one on the toe, then the one under the feet, like in the feet down. Okay, you can see it very well. It's actually mapped out that yes, there is a cone, there is that hardening, there is that bump, that rough area, but also having a center. Okay, it is well mapped out. It's like an eye. So that one is very characteristic of a cone. So this is how we can distinguish that. You can have Yomarabu, that is normal. Then when you have a cone, it usually brings you to hospital because of that pain. And at the same time, when you examine the patient, that is what you will find. But as you can see, those are areas which receive a lot of pressure when someone is walking. The one on the small toe is usually because of the shoe. Someone is putting on an ill-fitting shoe. Okay, so it tends to cause friction and eventually the body responds by forming such a thing. All right. So I hope now you can tell that the difference between the two. So how do you treat? Treating these things usually starts with prevention. Because just imagine this is your body responding to an insult you are making yourself. So your body responds by causing a modification. One, you want to prevent it. How? Tell this patient to be putting on normal or nice fitting shoes. Okay? Not very tight, so that you don't cause that friction and miss the modification. And then if a patient comes to you, they have them recurring, someone has them now retreat, they come back again over and over again, then you consider referring them to an authority personnel so that they can put some inner soles in their shoes as well as metatarsal bars. Sometimes they can put bars on top of the shoe where the metatarsals touch the shoe so that you don't have a lot of friction there. Then number two, if now someone comes to you with them, the therapy can be done using two methods. Okay? The first method is usually to apply keratolytic therapy, or you can go ahead and do surgical debridement. So, or you can do both of them at once. So, for keratolytic therapy, you want to cause a breakdown of that thickened skin. So, normally, your skin has that keratin, okay? And it's too much in your stratum corneum, which is the upper surface of your skin responsible for that hardening. So these different therapies that we use to manage tend to just reduce or they cause keratin. They cause the breakdown of that keratin so that you can dissolve off the cells which have thickened and then you create